Good evening and very warm welcome on behalf of Alchem Metabolics team to each one of you. My name is Dr. Mayur from medical team of Alchem. Sincerely welcome you on this Saturday evening for very interesting session on Ominous Octet Smart Summit. Indeed, the pathophysiology of diabetes has evolved right from disharmonious quartet to quintessential quintet, cetaceous sextate, septicidal septate, and now ominous octet. We are trying to identify and kind of treat all the possible pathophysiological mechanisms involved in the diabetes and thereby ensuring good blood sugar control. So we have power packed session in next 2 hours with our international speaker, Professor Ralph, who has kind of invented this term of ominous octet and done tremendous work there. And our Indian faculties, very renowned figures all across India. So it's my privilege to again welcome you all for this session and introduce our speakers and panel members. So Professor Ralph DiFronzo, welcome and thank you so much for accepting our invitation today for this session. And the Professor Ralph doesn't need any introduction. He's a professor of medicine and chief of diabetes division at University of Texas in Texas. And he is known for his pioneering work in the pathophysiology of diabetes, including the current paradigm of ominous octet. For this work, he has received multiple national and international awards, including the prestigious Banting Award and the Cloud Burnell Award from EASD. And he has more than 800 publications in peer-reviewed journals, and he has given numerous orations across the world in the field of diabetes. Professor Ralph, welcome again, and very eager to hear from you in next few minutes. So we also have Dr. Avdesh Kumar Singh sir today as a moderator. Sir, welcome and thank you so much for accepting our invitation. He is a consultant senior endocrinologist from Kolkata, and he is a deputy editor of Multi-Clinical in Diabetology, associate editor for IJDDC, and he has more than 130 scientific publications of national and international repute, and he has given multiple orations and lectures across national and international conferences in last decade. So thank you, sir, and welcome once again. In panel today, we have Dr. Professor Anil Bansali, sir, who is a professor and head of endocrinology department of prestigious PGI Chandigarh. He has done significant work in the stem cell therapy of diabetes and its related complications. His work on utility of HbA1c and the diagnosis of T2DM is absolutely phenomenal and has received multiple eyeballs. He has published more than 460 articles in indexed and peer-reviewed journals, and he has received numerous awards and accolades for his work, including Professor Vishwanathan Award for Stem Cell Therapy and Professor Deepak Banerjee Award, to name the few. Welcome, sir, and looking forward to hear from you. We have Dr. Bipin Kumar Sethi, sir, today as a consultant endocrinologist from Care Hospital, Hyderabad, south part of our country. He was associate professor at prestigious Usmania Medical College, professor and at Karnool Medical College and Gandhi Medical College, Hyderabad. He has several publications to his credit, and he has given numerous orations in multiple forums. Welcome, sir, and thank you so much for joining in. And last but not the least, we have Dr. Shirang Godbole, sir, who will be joining in a while. He's a consultant endocrinologist from Pune. He has multiple publications to his credit, including the co-authorship of Full Life with Diabetes, and Marathi edition of Madhumeha, which is a great book for common people. He has given multiple lectures across Maharashtra and India, and has multiple publications to his credit. This is the today's agenda for the meeting. After my introduction in next few seconds, Professor Dr. A.K. Singh sir will set the context and then hand over session to Professor Ralph for his deliberation on ominous octet, followed by a result of Messenger trial deliberation by Dr. Anil sir, followed by panel discussion with each one of us. So I request you to keep yourself kind of attentive here, and we'll take the question answer session post the deliberation from both the speakers. And now I'll hand over a session to Dr. A.K. Singh sir and request him to take the proceedings, please. Over to Singh sir.
Thank you, Dr. Mayur. Thank you, Alkem. It's an honor to moderate this session being given by Professor Di Franjo. I don't think he need any introduction to any one of us here in India or anywhere in the world. Suffice to suggest that when you are talking diabetes and the pathophysiology of diabetes, you cannot forget Professor Di Franjo and his contribution. As you all know, he was one of the first guys to deliver the Banting lecture on this particular topic in 2008, and the Claude Bernard lecture at ESD on the similar, topic. He is the man who discovered the additional 5 pathophysiology of diabetes. So from classical triumvirate to ominous octet, menu says, means from 3, point of target to the 8 point of target, the additional 5, problems associated with pathogenesis of diabetes was discovered by him. And it's my honor and privilege to moderate his session. Without wasting time and further ado, I would like to invite Professor Di Franjo to go through his presentation on classical triumvirate to ominous octet.
Great. Olga, how do I get this up now? Share screen? Come here, please. Come here, please. Just give me a second, please. All right. I need.
What did you? You share screen.
There we go. Can people see this screen now?
Yes, sir. It is visible.
Okay. Hold on.
Absolutely fine to go.
Yeah. Just give me one more second here. Reduce this in the up. Good. Okay, I think we're all set now. I can see the screen and hopefully you can see the screen. So it's a great pleasure for me to be with you here this evening for you, this morning for me. We are going to talk about the ominous octet. And one of the major reasons for starting with the ominous octet is that if you understand that there are 8 pathophysiologic disturbances that are present in people with type 2 diabetes, it'll be very clear that you're going to need multiple drugs used in combination. There is no one anti-diabetic agent that's going to correct 8 problems. And that now has led us to down the road where we really should be, right from the beginning, be using multiple drugs if we really want to get our diabetic patients under control. So let's start a little bit of background. In the United States, we have about 34 million people. It's almost 10% of the U.S. population who has diabetes. We anticipate that this is going to grow to about 39 million by the year 2025. And what you really need to remember is that for every person with diabetes, there are another 2 people who have pre-diabetes. But I wanted to put up the statistics from India to show you that as bad as it is in the United States, you're actually doing even worse in India. So you have 77 million people with type 2 diabetes, 13% of the population, and insulin resistance is a particularly characteristic feature of type 2 diabetes in India. And as I know that all of you who are listening in are well aware, the diabetes associated with significant morbidity comes in the form of eye, kidney, and nerve damage. But what really kills our patients are the heart attacks and strokes. And so, as you see, as we'll go through this presentation, it's going to be important to start with the correct drugs. They're going to lower the glucose and that have cardioprotective and renal protective effects. It's important to start early in the natural history of the disease. And it's going to be important to start medications in combination if we're going to correct these 8 problems. So how are we doing in the United States? And my guess is that similar type numbers are available from India. So this is what's happening in the A1C. The bottom line in white are the percentage of people who have achieved an A1C less than 7, starting back in year 1999 and coming up to the present time. You can see from 1999 to 2002, we actually did a little bit better. We went from 44 to 56% of people now having an A1C less than 7. But you can see we've kind of slipped in the last 10 to 15 years. The top line is the number of people with an A1C less than 8. And it's very clear we still have 25 to 30% of people who have an A1C that's above 8. And of course, these elevated A1C levels are what is associated with the microvascular complications. The cardiovascular complications are less associated with hyperglycemia than they are associated with the typical risk factors, which we'll talk a little bit about: hypercholesterolemia, hypertension, obesity, and something that I think is less well appreciated, insulin resistance. Now, why is it that physicians fail to achieve the level of glycemic control that will prevent the microvascular complications? Well, I put at the top of the list the treat to fail approach, and we hopefully are going to convince you after today's lecture that you need to go away from the treat to fail approach. So the treat to fail approach is I start you on the first drug, it's usually metformin, and then when you fail, you add a second drug. In the United States and worldwide, the second drug is sulfonylurea. I rarely use sulfonylureas in my practice. And then when sulfonylureas fail, we add a third drug and so forth. So we're always playing catch up. We're never ahead of the A1C. And because of this, we fail to achieve an A1C level that's less than 7. And in my opinion, ideally should be less than 6.5. Another important reason is called physician inertia. We know from multiple studies throughout the world, the A1C comes back and it's above 7 or even above 8. And it takes physicians many months, unfortunately, sometimes years, to institute a change in the medication. Patients are also a problem. Patient noncompliance. If the patient decides they're not going to work with the doctor or take their medications on a regular basis, that is a major cause of inability to control the A1C. In many countries, the cost of the medications, especially the newer medications, is a problem, and has been alluded to already by Dr. King. We know that there's a very complex pathophysiology, the ominous octet, and if we got 8 problems to correct, we're going to need multiple drugs to correct these problems. So this is the classic stepwise treat to fail approach that has been put forward by the American Diabetes Association for multiple years. You see here on the left, we start the first agent, the A1C drops below the goal, but then you can see with time the A1C rises. At this point, we add a second agent, we get the A1C under control, but then again, the medication starts to wane in effectiveness. The A1C now is out of control, and this continuing spiral goes on, and people fail to achieve an A1C that's less than 7 to 7.5. And in fact, as I pointed out to you, 30% of people have A1Cs that are above 8 in the US and worldwide. So we clearly need to change this sort of treat to fail approach. Now, why is it important to initiate therapy aggressively and to keep the A1C down right from the beginning? I'm going to use 2 very famous studies to make the point that initiation of therapy early makes a difference in the long-term complications. So the first study that I'm going to review for you briefly is the Diabetes Control and Complications trial. This was a study done in people with type 1 diabetes, and it's a very long-term study. These people have been followed up for 26 years. So if you look to the left-hand side of the panel, these are type 1 diabetic patients starting with an A1C of 9. Conventional therapy, you can see over the first 8 years, there really was no decrease in the A1C. In the intensive therapy, the A1C fell from 9 to 7, and it pretty much stayed down for the subsequent 8 years. Now, the trial ended at the end of year 8, and the people who were in the intensive therapy found they couldn't keep up with the intensive therapy. And with time, you can see in orange, the A1C started to rise. The people who were in the conventional therapy said, oh, wow, look at all the benefit that the people in the intensive therapy got. So we want to intensify our therapy, and the A1C came down. And then you can see over the next 25 years, the A1C in both groups was the same. So we're going to look at this 8-year period after the formal part of the trial ended and see what happens to the microvascular complications. So to the left now is progressive of diabetic retinopathy. And you can see over the 8 years after the formal part of the trial ended, the people in the conventional therapy, even though they had the same A1C as the intensive therapy, you can see in yellow, there was progression of diabetic retinopathy, quite marked progression compared to the people in the intensive group. But remember, the A1C is identical throughout this 8-year period. Now, if we look at clinical albuminuria, meaning albumin excretion greater than 300, you see exactly the same picture. The people in the conventional therapy group, a marked increase in macroalbuminuria compared to the intensive group, even though the A1C in both of these groups is identical over these 8 years. So this tells us early intervention, early control of the A1C makes a big difference in terms of the long-term complications. So you might say, well, what about type 2 diabetics and what about macrovascular complications? So I'm going to use the United Kingdom prospective diabetes study to make this point. This is Dr. Robert Turner's study. It was the first study that showed us that a good glycemic control in type 2s made a difference in terms of decreasing eye, kidney, and nerve complications. But what I want to do is focus on, to the left, all-cause mortality, and then to the right, a myocardial infarction. So if you look at this white dotted line as a function of time since diagnosis on the x-axis, we're going to plot the hazard ratio for dying, all-cause mortality, and most of this is cardiovascular mortality. That's showed here by the dotted line. Now, that's assuming that we start the therapy at the time of diagnosis. Let's take a look at the yellow dotted line. Let's say we wait 5 years to start the intensive therapy in terms of glycemic control. You can see this curve is shifted to the right, meaning that these people have a marked increase in the likelihood of dying because the therapy was started 5 years later. And if we look now at the red line, if we wait 10 years before starting the therapy, you can see a further shift to the right, meaning a further marked increase in the likelihood of dying from a cardiovascular event. And if we look at myocardial infarction, these three curves parallel those for all-cause mortality. So what the DCCT and the UK PDS trial have told us is that we need to start early. And I'll make the point later. You need to start with the right medications, and you need to start with the right medications in combination, and you need to get the A1C under control. And that, of course, is in addition to correcting all of the other cardiovascular risk factors. And if you do so, it makes a difference in terms of what's going to happen 10, 15, 20 years after the diagnosis. Now, this is another very important slide. It comes from data which is just recently published in the New England Journal of Medicine in December of 2022. This is called the GRADE study. And the great study, if you can read in the top, is glycemic reduction approaches in diabetes. And this is a study funded by the National Institutes of Health. And what they wanted to do is to take people who are on metformin who were poorly controlled. And you can see here, mean A1C is about 7.5. And then they're going to divide them into 4 groups. One group that we're going to add a sulfonylurea glimepiride to the metformin. Another group we're going to add sitagliptin, that's in yellow. A third group we're going to add liraglutide, and a fourth group we're going to add glargine. And I think you can see that the results are in general really quite similar. Once we add the therapy initially in the first 6 months, there's a nice drop in the A1C. But quite strikingly, in every one of these 3 groups, after the first 6 months, there's a progressive and relentless rise in the A1C. The group that ended up doing the worst was the sulfonylurea group. And quite frankly, we know this from many, many sulfonylurea studies. Next are the people treated with sitagliptin. The people treated with liraglutide did a little bit better, but you still see even the GLP-1 receptor agonist group, there was a deterioration. And in, intensive insulin therapy with glargine actually really didn't do much better. And the reason for the failure here is because all of this is monotherapy, and we're not correcting all of the pathophysiologic abnormalities. And I would say that the GREAT study, more than any other study, has now emphasized that we definitely need to start with combination therapy from the beginning. So type 2 diabetes is a very, very multifactorial disease. And when I gave the Banting lecture in 2008, I titled it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. Now, when I gave the Lilly lecture in 1987, it was just simply called the Triumvirate. We know that there's insulin resistance in the liver in the lower left. This insulin resistance in the liver is manifested by an overproduction of glucose throughout the sleeping hours. This leads to fasting hyperglycemia. We know there's insulin resistance in the muscle. The diabetic wakes up in the morning and have breakfast, lunch, and dinner. That glucose, the carbohydrate that's in the meal, needs to be taken up and disposed of in the muscle. But the muscle is insulin resistant, so you get postprandial hyperglycemia, post-meal hyperglycemia. And we also know that this progressive beta cell failure is quite characteristic of our diabetic patients. And beta cell failure in the presence of insulin resistance leads to a marked increase in the A1C. But as I pointed out in my Banting lecture, we have at least 5 other problems, and I could probably add a couple more cents, but I'm just going to focus on these other 5 problems. The fat cell. So what's driving the epidemic of diabetes is the epidemic of obesity. So we know that when you take in excess calories, those calories are stored in the fat cell. But as the fat cell starts to expand, it becomes resistant to insulin. And when it becomes insulin resistant, it starts to break down the triglycerides, and it releases free fatty acids into the bloodstream. Now, we as physicians don't normally measure the plasma FFA concentration, but if you did, you'd find that the FFA concentration is very high. And we have shown in multiple studies that elevated FFA impair insulin secretion by the beta cells, cause insulin resistance in the liver, insulin resistance in the muscle. So this defect in the fat cell exacerbates the triumvirate. We've also come to learn there's a major defect here at the gastrointestinal tract. So when you eat a meal, you release 2 GI hormones, GLP-1 and GIP. These 2 incretin hormones account for 70% of the insulin that's released in response to the meal. And it turns out that the GLP-1 and GIP have become very resistant at the level of your beta cells. And of course, from the therapeutic standpoint, we give you an injection of a GLP-1 receptor agonist to overcome this beta cell insulin resistance. Now, because, of course, this is an injection that we give therapeutically, you cannot combine it into a tablet. Even though GLP-1 receptor agonist therapy is very effective, for today's presentation, we're not going to focus on that. We're going to focus on the tablet medications that can be combined. We also know that the alpha cell overproduces glucagon, and the hyperglucagonemia further drives hepatic glucose production, raising the fasting glucose concentration. Studies that we did many years ago showed for the first time that the threshold for spilling glucose in the urine is markedly increased in people with type 2 diabetes. In you and I, the threshold is about 180, but in the diabetic, that threshold is markedly increased. And then lastly, we know that the brain plays a very important role in the pathophysiology of the disease. So when you eat a meal, you release GLP-1 in other molecules that shut off your appetite. Well, it turns out your brain, the appetite regulating centers in the hypothalamus, have become very resistant to GLP-1. This contributes to the weight gain. And when you gain weight, you become insulin resistant in muscle and the liver. So it should be obvious then that if you have 8 metabolic problems, that you're going to need multiple drugs to correct these 8 problems. And you need to start early in the natural history of the disease. Now, in the United States and throughout the world, the number one drug which is started in most patients is metformin. For those of you who don't know my background, I actually brought metformin to the United States in 1995. And I like metformin. It's a good drug. But as you're going to see, metformin alone is not going to be able to lower the A1C and keep it down. And that has to do with its mechanism of action. Now, most people think that metformin is an insulin sensitizing drug. And I can assure you, since I did all of the work to get metformin approved by the FDA, including insulin clamp studies to measure the effect of metformin on insulin sensitivity, metformin is not an insulin sensitizing drug. This is a major misconception. So how does metformin work? The major mechanism of action is metformin. These are the original studies done with radioisotopes to show that in diabetic patients, here in yellow, they have a markedly increased rate of hepatic glucose production. And when I treat these patients with metformin, I markedly lower the rate of glucose production throughout the sleeping hours. And this is what causes the decrease in fasting glucose concentration. So in the right-hand panel, on the y-axis, I've plotted the individual data points for hepatic glucose production for each patient. And then on the x-axis, the fasting glucose. You can see the yellow points. The mean fasting glucose is close to 200, and they have a markedly increased rate of hepatic glucose production. And I'll treat them with metformin, and after 6 months, you can see the very nice decrease in fasting glucose that's related to the very nice decrease in hepatic glucose production. Now, we also did euglycemic insulin clamp studies in these patients. The insulin clamp, we infuse insulin, and then with radiolabeled glucose, we measure glucose uptake by all tissues in the body. And these data were all submitted to the Food and Drug Administration. And you can see here before in yellow and after in orange. There's absolutely no improvement in insulin sensitivity. So metformin is not an insulin sensitizing drug. This is a major misconception. Now, if we now come back to the ominous octet, you can see here that metformin corrects only one of the problems of the ominous octet. It works here on the liver. Now, in order for metformin to work, it has to get into cells through the organic cation transporter. And the organic cation transporter does not exist in muscle. So metformin can never, ever accumulate in muscle. And that explains why it is not an insulin sensitizer. On the other hand, the organic cation transporter is abundant in liver. And that explains why the major effect of metformin is on the liver. Now, what about the SGLT2 inhibitors? So I invented this class of drugs But unfortunately, I published all of the data in the Journal of Clinical Investigation in the late 1980s and early 1990s. And that means that I don't own the patent rights for this class of drugs. But we have 4 of them now here in the U.S. There are many others in Pacific countries such as Japan: dapagliflozin, canagliflozin, empagliflozin, ertugliflozin. Because these drugs work by blocking glucose reabsorption in the kidney, by blocking the SGLT2 transporter, they cause an increase in glucose excretion in the urine, and they lower the glucose, but they all work by the same mechanism of action. So the benefits of these drugs really are quite similar, as I will show you in the following series of slides. So these are the original studies that were done with dapagliflozin and published in Diabetes Care in 2013. So this is what a renal glucose titration curve looks like. If I plug in an IV, we start with a fasting glucose is about 90 to 100, and then I'm going to increase the glucose concentration. And as I raise the glucose concentration up to 180, you can see on the y-axis, no glucose appears in the urine. But when I get a glucose concentration to 180, and I continue to infuse the glucose and raise the plasma glucose, now all of the glucose that's filtered above that ends up in the urine. And this is a normal glucose tolerant individual with an A1C of 5. Now, what about if you become diabetic and your A1C rises to 6.5? So this is the mean A1C in this paper. So there were some people between 6.0 to 6.5 and some between 6.5 to 7, but the mean value was 6.5. This is the level at which we make the diagnosis of diabetes. Now look what happens here. The threshold to spill glucose in the urine has increased already to 205 milligram per deciliter. And if we look at diabetics with an A1C of 7.5, you can see a further increase in the threshold, and 8.5 and 9.5. Now the threshold can increase to 260 milligram per deciliter or above. So now, as physicians, what we would like is the diabetic kidney to be dumping the glucose in the urine when the glucose goes and exceeds 180. But the more the glucose exceeds 180, the more the kidney is hanging on to the glucose. So how do the SGLT2 inhibitors induce glucosuria? So the initial studies were, again, done by us, and they were done with dapagliflozin. But we've shown very similar data for empagliflozin and canagliflozin. So here is the typical renal glucose titration curve in you and I. We raise the glucose up to 180, no glucose in the urine. Above 180, progressive rise in glucose in the urine. Now, here's the diabetic. That threshold is significantly increased. Schematically here, I've shown it at 220, but the higher the glucose, the higher the threshold. Now, when I put you on dapagliflozin, how low do I lower the threshold? Do I lower it back to 180? Nope. Do I lower it back to your fasting level? Nope. I actually lower it to well below your fasting glucose. I lower it to about 40 milligram per deciliter. So what does this tell us? It tells us that there is no such thing as a non-responder to this class of drugs. Why? Because in even someone who has normal glucose tolerance and a fasting glucose of 80, I'm going to lower the glucose fasting below 80, and that normal glucose tolerant individual is going to dump 50, 60, 70 grams of glucose in the urine. So you might ask, well, why didn't that person become hypoglycemic? So in doing these studies, we discovered a whole new physiologic axis that connects the kidney to the liver. So as the glucose starts to appear in the urine, there's a signal that goes to the liver, and the liver produces an amount of glucose which is exactly equal to the amount of glucose that's coming in the urine. And therefore, you can never make even a normal glucose tolerant individual hypoglycemic. So this is a very, very beneficial effect of the SGLT2 inhibitor class of drugs. Okay. And this class of drugs meets a very important number of needs in our diabetic patients that really are suboptimally corrected. So we have this new pathophysiologic defect at the level of the kidney, where the threshold is markedly increased for glucose reabsorption, and we lower it. As the glucose level comes down, we reverse what we call glucotoxicity. It's another concept that we developed many, many years ago, in which we showed that chronic sustained hyperglycemia induces insulin resistance in muscle and liver and impairs beta cell function. So as we reverse glucotoxicity and we improve insulin sensitivity and beta cell function, A1C comes down. Because we lose calories in the urine, people lose weight. And on the right-hand panel here, you can add the SGLT2 inhibitors with any other class of anti-diabetic agents, because the SGLT2 inhibitors work by a completely different mechanism. You block not only glucose, but sodium reabsorption in the proximal tubule, a little negative salt and water balance, nice reduction in blood pressure, no hypoglycemia. So we get improved glycemic control, and we correct a number of cardiovascular risk factors you might expect to be observed at cardiovascular protection. I'll come back to that in a second. So let me just show you some typical studies looking at the effect of dapagliflozin on the A1C. As we go from left to right, we're going to add dapagliflozin to patients on monotherapy, on metformin, on sulfonylurea, pioglitazone, insulin, or sitagliptin. Baseline A1C is about 8. Now, dapagliflozin comes in 2 doses. The light orange is 5. The dark orange, 10 milligram. Placebo is yellow. But as you go across the board, whether you're adding it as monotherapy to metformin, et cetera, to sulfonylurea, you're getting at about 1% drop in the A1C. So if you start with an A1C that's about 8, and I drop you to 7, this is a very desirable reduction in the A1C. Now, what about body weight? Because you lose calories in the urine, you might also expect to see some body weight. So the baseline body weights are shown here at the top. So when I add it, dapagliflozin as monotherapy at 5 or 10 milligrams, you see you lose about 2 to 2.5. Same thing with metformin. Sulfonylureas tend to make you gain weight. All of the weight gain with sulfonylureas is reversed. Pioglitazone makes you gain weight. The weight gain is neutralized with the dapagliflozin. So the dapagliflozin, and the same thing is true for the other SGLT2 inhibitors, are very effective in lowering the A1C. They're also very good at lowering blood pressure data, which I'm not going to show you, and in promoting weight loss. So if we now come back to the ominous Octet, you see here to the right, the primary effect of the SGLT2 inhibitors on the kidney. I increase glucose excretion in the urine. As I reverse glucotoxicity, insulin sensitivity and muscle improves, and beta cell function improves. And now with metformin, you can see here we've corrected 4 of the important problems that are present in our diabetic patients. So obviously, metformin and an SGLT2 inhibitor is going to be a very good combination. So here is a study which we were involved with, looking at combination therapy with dapagliflozin and metformin. So this is the 10 milligram dose of metformin, of dapagliflozin, and a very large number of people, over 600, and they're poorly controlled A1C above 7. There's a run-in period, and then they're randomized to, on the top, dapagliflozin and metformin, and the dark red, the lighter red color, DAPA 10 milligrams in placebo, and at the bottom, metformin and placebo. So if we start here over on the right-hand panel, metformin dropped the A1C by about 1.4. DAPA dropped it by 1.5. So both drugs are effective and very similarly effective. But when you put the two together, you get a 2 percentage point drop. You get an additive effect of the two drugs. Now, if we look at the drop in fasting glucose, the gray line is the drop in fasting glucose. It's about 34 with metformin. If we look at the drop in fasting with dapagliflozin, it's 46, and the two together, 60, again, showing on fasting glucose the nice additive effect. Now, what have we learned about SGLT2 inhibitors in cardiovascular disease? Well, our diabetic patients are at an incredibly high risk for atherosclerotic cardiovascular disease. So subclinical cardiovascular disease affects about 2/3 of our diabetic patients. And at the time you see a diabetic patient, some 15 to 20% already have clinically manifest cardiovascular disease. And what kills our diabetic patients, some 78%, 70 to 80% of the mortality is attributed to the cardiovascular disease, which manifests itself in our diabetic patients some 15 years earlier. And now that our diabetic patients are living longer, we're seeing a lot more heart failure, a 2 to 3-fold increase in type 2 diabetics. And if you develop chronic kidney disease, and remember that chronic kidney disease, type 2 and type 1 diabetes is the commonest causes now worldwide, there's a further marked increase in cardiovascular mortality. Now, the very first study showing the benefit of an SGLT2 inhibitor was done with empagliflozin. This is the EMPA-REG outcome study. And this was a very large study with over 7,000 patients, in which patients were randomized to placebo, which is the yellow curve, or empagliflozin, which is the orange curve. And the primary endpoint was the MACE endpoint. This stands for Major Adverse Cardiovascular Events. There are 3 of them: non-fatal MI, non-fatal stroke, and cardiovascular mortality. And if you want to get a drug approved in the United States, you have to show a benefit on the MACE endpoint for cardiovascular approval. And you can see hazard ratio is 0.86, p-value 0.004. The other point that I want to make here is these curves start to separate literally within 3 months. So the benefit is seen very early. Now, what was dramatic in the empagliflozin study was the effect on cardiovascular death, hazard ratio 0.62. And again, you can see almost instantaneously within the first month, you see this protection. And then to the far right, hospitalization for heart failure, hazard ratio 0.65. Again, early separation of the curves. Now, remember that all of the patients in the EMPA-REG outcome study got into the study because they had a previous cardiovascular event. So this is the highest risk patient population of all of the SGLT2 inhibitor studies. So rather than show you each individual study with dapagliflozin, canagliflozin, and empagliflozin, you're going to combine them here in one slide. So the DECLARE study is shown in yellow, Canvas with canagliflozin in green, and the EMPA-REG in purple. And if we look at the MACE endpoint, all 3 of them at the top, all the points to the left. Now, where there was some controversy had to do with cardiovascular death, where clearly the group treated with empagliflozin had a greater benefit in terms of cardiovascular mortality. But you need to remember that this group was the sickest group. Everybody who got into the EMPA-REG study had a previous cardiovascular event. If you look at the dapagliflozin people, this was the least sick group. 2/3 of the people got in because they had risk factors, only 1/3 because they had a cardiovascular event. So not surprisingly, this was the least effective in terms of cardiovascular mortality, Canvas in between. As we go down, all 3 drugs showing similar benefit in non-fatal MI. Somewhat surprising to us because these drugs lower blood pressure and it's still unexplained. No benefit in terms of decrease in stroke. If you look at heart failure and cardiovascular disease, all 3 clustered together. Heart failure alone enormous benefit from all three. And then the renal composite endpoint, which we'll come back to, hazard ratio 0.55, enormous benefit. So these drugs all have important cardiovascular protective effects. Now, here is the first study with dapagliflozin in patients with heart failure in reduced ejection fraction. The mean ejection fraction in this study was 30, and the primary endpoint in the study was hospitalization for heart failure, cardiovascular death, urgent visit, care visit for heart failure. So here's the primary outcome to the left. Hazard ratio is 0.74, highly statistically significant. Middle, hospitalization for heart failure, right, cardiovascular death, very, very similar. And again, I want to point out at the bottom, these curves show separation very, very quickly. So the sooner you start the drug, the better off you are. And in this study, there were both diabetic and non-diabetic patients, and both groups benefited equally well. So this has become a very important medication for the cardiologist because it now adds a new drug that they can use to treat people with heart failure with reduced ejection fraction. Now, how do these drugs work? I think that the major benefit of the drugs have to do with their hemodynamic effects. So these drugs lower blood pressure, and so they decrease the afterload, they decrease the plasma volume, they decrease the preload, and this now provides the cardioprotection. Now, the heart rate in all of these studies didn't go up, suggesting that there was inhibition of sympathetic tone. I'll come back to this in a second. There's also a marked decrease in arterial aortic stiffness, afterload reduction, and we now have data to show that, in fact, there is an important decrease in sympathetic nervous system activity. The other hypothesis, which I believe is important, is the ketone hypothesis, originally put forth by Professor Farinini. These drugs switch you over to ketone metabolism from glucose metabolism. Ketones are avidly taken up by the heart. And when you burn ketones, you generate more ATP with less oxygen consumption. So a very beneficial effect on the heart. Now, there are a lot of other mechanisms that have been put forth. I don't have time to go through all of these. These drugs decrease insulin resistance. They lower glucose. They decrease visceral fat. I'm pretty sure this decrease in uric acid has been excluded as a potential mechanism. These drugs increase the angiotensin 1-7 receptor system. This is the cardioprotective system. They decrease inflammation, oxidative stress. They inhibit the sodium proton pump, and they decrease intracellular sodium. So lots of potential mechanisms, lots of research going on in this area. Now, what about the SGLT2 inhibitors and diabetic kidney disease? So the original study here was done with canagliflozin versus placebo in diabetic patients who in which the combined endpoint was a doubling of the serum creatinine, halving of your GFR, or advancement to dialysis or transplantation. And you can see the combined hazard ratio for this endpoint is 0.70. And you can see a very clear separation of the curves by 12 months. And you see many zeros for the p-value. And canagliflozin was approved by the FDA. And this was really the first new drug, in addition to the ACEs and ARBs, for renal protection. Then we had DAPA-CKD, and you can see that the hazard ratio for renal protection, 0.56, was similar to that for credence. Highly statistically significant, big study, over 4,000 people. But what was important about DAPA-CKD is it had diabetic and non-diabetic patients. Polycystic kidney disease, people were excluded, but all other causes of renal disease were included, and we saw equal benefit in terms of slowing the rate of decline in GFR, whether you're diabetic or non-diabetic. Now, the usual mechanism that is put forward that the SGLT2 inhibitors has to do with glomerular tubular imbalance. Now, you can just follow the words here as I take you through this, and everything here is true for type 1 diabetes, but I'll come back and tell you what is going on in type 2 diabetes. So both type 1 and type 2 patients are hyperglycemic. That means they filtered more glucose. In the proximal tubule, they're going to reabsorb more glucose along with sodium, and that leads to a decrease in sodium delivery to the macular denser cells of the juxtaglomerular apparatus. The kidney perceives this as a decrease in circulating volume, and it does two things. It generates a signal that causes afferent, so the little arteriole going into the kidney dilates, more blood flow going into the kidney that increases the intraglomerular pressure. They also generates a signal that causes efferent arterial vasoconstriction, again leading to an increase in intraglomerular pressure. Now, clinically, we see this as manifestation, but what's causing the renal damage is the increase in the intraglomerular pressure. The ACEs and the ARBs work on the afferent arteriole, and in type 1s, the SGLT2 inhibitors on the afferent arteriole. However, just like there's an ominous octet for hyperglycemia in diabetics, this is my ominous octet for diabetic nephropathy. And you can see it's a very complicated problem. If you really want to prevent diabetic nephropathy, just control the glucose. You'll never see kidney disease. The most important factor that accelerates the decline in renal function is blood pressure. So all the guidelines now say you need a normal blood pressure, 120/80. Deranged tubular glomerular feedback we just talked about. This is clearly playing a very important role. The kidney is hypoxic because that sodium that is in the proximal tubule that's reabsorbed with the glucose needs to be pumped out. It's pumped out by the sodium-potassium ATPase pump. That requires energy. Hyperglycemia damages the podocytes. This allows albumin to escape into the glomerulus, and albumin in the glomerulus incites glomerulosclerosis. We know that there's a lot of fat in the kidney. This is lipotoxicity. There's tubular hypertrophy with release of growth factors, which can damage the kidney. And there's a strong genetic component. Again, 8 problems here. So what that's telling us is that no single drug is going to correct 8 problems. So we have ACEs and ARBs. They work here on the deranged tubular glomerular feedback, but we need other drugs. And so what about the SGLT2 inhibitors? You can see here, if you count them, 1, 2, 3, 4, 5, 6, 7. They correct 7 of the problems. Now, there's nothing that's going to correct the genetic problem. Yeah, you can go back and choose your parents again, but that's not difficult to do. So combining SGLT2 inhibitors with ACEs and ARBs are very good drugs. And most recently, we've had approval of feninerone, a mineralocorticoid receptor antagonist. So we actually have 3 good drugs for preventing diabetic nephropathy. Okay, let's take a look at DPP4 inhibitors. When you ingest a meal, you release GLP-1 and GIP, and these markedly increase insulin secretion. Now, in the bloodstream, there's an enzyme, dipeptidyl peptidase 4, that is going to chop off 2 terminal amino acids, and this inactivates GLP-1 and GIP. So what do the DPP4 inhibitors do? They block this degradation of the GIP and the GLP-1. So now when you ingest a meal, instead of degrading and lowering the GLP-1 and GIP levels, the DPP4 inhibitors allow the body to maintain an increase in GLP-1 and GIP. Now, what about these drugs? I want to show you some data here with saxagliptin, and I'll also show you some data with sitagliptin. They basically are very similar. When you add them to drug-naive patients or to sulfonylurea patients, the blue, or metformin, the pink, or pioglitazone, you get about a 0.7 to 0.8 drop in the A1C. So this is a study that we carried out with empagliflozin, but we've done a very similar study with dapagliflozin as well. So here we're going to take empagliflozin as monotherapy, and we're going to combine it with a DPP-4 inhibitor, linagliptin. There's a screening procedure, placebo run-in, and then the patients are randomized 1 to 1 to 1 to 1. One group, if we start down here in the bottom, is going to get linagliptin. One group gets empagliflozin 10, empagliflozin 25. Now, we've done the same study with DAPA-5 and DAPA-10. And then we're going to combine the EMPA with lina, or the EMPA higher dose with lina. And we've done a very similar thing with dapagliflozin. Let's start over here on the right. Starting A1C is 8. Linagliptin drops you about 0.5. The SGLT2 inhibitors are clearly more potent. So here's 10 of lina, 25. I'm sorry, this is 10 of empagliflozin, 25 of EMPA. I could substitute 5 and 10 of dapagliflozin. Very nice drop, about 1%. And when I put the DPP-4 inhibitor with the SGLT2 inhibitor, I get an additive effect on A1C. Now, what about cardiovascular safety? Because any drug that we use in a diabetic patient, we want it to be safe for our patients. So we actually have very good data here. Here's saxagliptin in the SAVIOR trial, alogliptin in the EXAMINE trial, sitagliptin in the TACOS trial. I could add the linagliptin trial, be very similar. You can see that the placebo and the treatment curves overlap for unity, meaning that these drugs are completely safe from the cardiovascular standpoint. So let's come back now to our ominous octet. As you can see now, we're doing a pretty good job here. So we can add here our DPP-4 inhibitors. They're going to increase GLP-1 and GIP. So there's a little modest increase in insulin secretion. They inhibit glucagon, and the increase in insulin and decrease in glucagon decrease hepatic glucose production. As we said, metformin has its major mechanism on the liver. And then we have the SGLT2 inhibitors working on the kidney to enhance glucose excretion. And with reversal of glucotoxicity, we improve insulin sensitivity in the muscle, and we improve beta cell function. So you can see that this triple combination with SGLT2 inhibitor, metformin, and DPP-4 are correcting 7 of the 8 problems for the ominous octet. So this is going to be a very good combination. This problem here at the level of the fat cell is still one that yet to be treated. So finally, the American Diabetes Association, for the first time in their standards of care, you see this is 2022, I'll just read this to you, have come to the point that they recognize that combination therapy is important. And the statement says, because type 2 diabetes is a progressive disease, maintenance of glycemic targets with monotherapy is often possible for only a few years. Traditional recommendations have been to use stepwise addition, the treat to fail approach of medications to metformin. However, there are data to support initial combination therapy for more rapid attainment of glycemic goals and longer durability of glycemic effect. And they cite 2 references. I'm pleased to see that the first reference that's cited is our reference, Dr. Abdul Ghani and myself. This is the EDICT trial. The 3-year data have recently been published, and the 6-year data have been published in abstract form. And this is Dr. Matthews in Del Prado's data from the VERIFY trial. So now even the American Diabetes Association agrees that we need to start to consider combination therapy from the very beginning. So that's the last slide that I was going to show you. I want to thank you for your attention, and I'm going to turn it back to our moderator. We have some more presentations, and then we'll have time to answer all of your questions. Again, thank you very much. for your attention.
Thank you. Thank you, Professor Diffranjo. It's always mesmerizing. Every time I'm listening to you, I learn something which I wasn't aware. So we will take all the Q&A during the panel discussion. So we have got another talk. So thank you very much. Please join us during the panel discussion. So I'm collecting all Q&A for you from the audience across the country. I've been informed that more than 5,000 people was listening to you at the moment.
Oh, great.
Yeah. Thanks a lot. Okay, so let's shift our gears from now to the next topic. And I would like to invite Dr. Professor Bansali for this presentation on Mesida trial. So we have got one double-blinded active comparator trial conducted in India, and this is called Mesida trial. Mesida, basically, the M stands for metformin, S stands for sitagliptin, and D stands for dapagliflozin. This Mesida trial was done on behalf of Alkem. So a sponsor was one of the Indian pharma giant. They did a double-blind randomized active comparator trial and compared a triple drug combination of sitagliptin, metformin, and dapagliflozin to the innovator MSD's Genomate XRCP, which is sitagliptin and metformin extended releasing combination of 100 milligram sitagliptin and 1000 milligram metformin head-on. And in this trial, the triple drug was found to be superior compared to the sitagliptin and metformin. I would not unnecessarily waste time. Dr. Bansali doesn't need introduction to the Indian audience. He is the giant in diabetes and endocrinology in India, and under his belt, several DM PhD fellow has passed out from endocrinology. Professor Bansali, floor is yours. Ganesh?
I think sir has logged out. Once again he will join in few seconds.
Okay. So before Dr. Bansali comes on, let me know once he joins. I can map him. Right. So he just logged out. Maybe some technical glitch. So before Dr. Bansali comes, let me pass on some questions to Professor Diffranjo. Let's not waste time.
Yep.
See a few, good questions from the audience. Well, so someone asked me, it's a very, provocative question. So the question is, someone has to choose between two doses of empagliflozin, 10 milligram and 25 milligram. What would you prefer to choose between? Is there any significant benefit of 25 milligram empagliflozin over 10 milligram?
Yeah. The difference is about a difference in A1C of about 0.2. And that is also true for dapagliflozin 5 and 10 milligrams. So personally, even though the package insert in the United States says you should start from 10 and go to 25 for EMPA or 5 to 10 with DAPA, I always go to the higher dose. So I always start with the 25 of EMPA or the 10 of DAPA. Importantly, there are no adverse side effects that you get when you go from 10 to 25 of EMPA or 5 to 10 of DAPA. So I just go with the higher dose right from the beginning.
Yeah, but then Dr. Diffranjo, once we look into the CB outcome trials, barring Impareg, we didn't use 25 milligram of empagliflozin in any of the empagliflozin trials, starting from Emperor reduced to Emperor preserved to Impart. Yeah. We always used empagliflozin 10 milligram. So, right. So I would agree with you that when it comes to HbA1c, there may be a marginal dose-dependent reduction in HbA1c, but we don't have great evidence when it comes to heart failure or kidney outcome, because IMPA 25 was not studied in any of these trials. Do you agree with me?
So you are absolutely correct. But now for dapagliflozin, they only use the 10 milligram dose. So for DAPA, they use the 10 milligram dose. So you could argue you should never use the 5 milligram dose because all the cardiovascular outcome trials were done with 10. Personally, I don't think there would be any difference between 25 and 10 of the EMPA. But because the cardiovascular outcome trials were done with 10 versus 25, if you felt that there really would be a difference, you can use the 10. I don't think there's a difference. So I would just use the 25, just as for dapagliflozin, I always use the 10. But one could argue that you should simply go with the data that are from the trial. In this situation, I just kind of ignore the trial. The dose, yeah.
So I can see Dr. Bansali had joined. Ganesh, is that correct? Dr. Bansali, are you there?
Yes, he is there, sir.
But I can't see his video on.
Yeah,
we don't see his face yet.
Manager is there with the doctor.
Here he comes.
Yeah. The audio. Yes, sir. You are now, I think.
Dr. Bansali, please put your video on.
Video.
Now it is on?
Yes.
Yes. Yeah. So welcome, Dr. Bansali. Good evening.
Good evening, Adesh.
I have already introduced you, so the stage is set for you.
Yeah.
Let's.
Thank you, Adesh.
Yeah, my pleasure.
Yes.
Please go ahead.
Yeah. So, where are our slides? Yeah. Okay.
Yeah, so put your mobile off and continue with the laptop because
Yes, mobile is off.
Yeah.
I'm just putting I'm sharing my screen
Okay.
with my slides. Yes. Yes, so yeah. Slides are visible now?
Yes, absolutely. Please go ahead. Yeah.
So what Dr. DiFranco has already made a ground for that it's a time to use the combination therapy to begin with rather than a sequential therapy as advised by your ADA ESD guidelines. So I think AS is definitely more aggressive. So they talk about the combination therapy, and we have really become wiser after the verified trial, which has showed us that even at a hemoglobin A1C of 6.9%, you are using a combination of the two drugs, which may contribute to greater sustenance to a target hemoglobin A1C for a longer time, as opposed to if you use the drug sequentially. So I think it's a time which has come now that how many defects you target at a given point of time, one, and secondly, how fast you target all these part of Octet. So this is a MESITA trial. That's a fixed dose combination of a metformin, dapagliflozin, and sitagliptin. Yes. So the rationale of using the combination of these three drugs together is the mechanisms are complementary. Mechanisms are the action of all three drugs has a glucose-dependent action, and thus the hypoglycemia risk is lower. And metformin being a weight neutral, DPP4 being weight neutral, and SGLT2 inhibitors causing weight loss. So additional, you have the advantage of this class of drug together. And lastly, the compensatory effects of SGLT2, particularly increase in glucagon and increase in hepatic glucose output, they are contracted by metformin and DPP4 inhibitor. So it sounds very good that all these three drugs together, if you use, you are targeting at least 7 out of 8 these defects, one, and secondly, they are all complementary to each other. So this is the already have been talked Octet, and we are all fan of this Octet for a long time, and it has given a lot of insights and into the pathogenesis of type 2 diabetes. and it has become really possible to target almost all these part of Octet. So this dapagliflozin, so the low risk of hypoglycemia even in a small pill. As I mentioned, that dapagliflozin, it's a glucose independent mechanism. Sitagliptin, it's a glucose dependent insulin secretion, and the metformin mainly reducing the hepatic glucose output and rarely causes hypoglycemia. Then FDC. Why we should use FDC? I think if you talk about the use of FDC and the patient's compliance, whenever you use a free dose combinations, the compliance is around, you can see that here the data is around 15% had a poor compliance. But if you use a fixed dose combination, certainly the compliance is reduced, compliance is increased, and the pill burden is reduced. And even when you use the combination of 3 drugs together, the cost is also lesser as opposed to 3 individual pills. So the definitely compliance is definitely better when you use a fixed dose combination. And in Indian patients, I think in patients everywhere, not only in Indian patients, the poor adherence is I think it's a phenomenon that patients, they do initiate with the therapy, but they are not able to adhere and they are not able to titrate. I think that's one of the major challenges we are facing now in the management of diabetes, that even on insulin side, patients start insulin, they may adhere, may not adhere, that's one, but they never intensify. So neither they intensify nor they adhere, and eventually they have a bad glycemic control. So I think the poor glycemic control and diabetic complications is an outcome of poor adherence and poor intensification. I think these challenges should be discussed and should be hammered to the patients every time, is that they should use these medications not only to use, but use to titrate and really achieve the targets. So this is the fixed dose combination pill. I think again summarized here. The simple doses improves therapy adherence. That's one we have already talked. It's a safer, rapid, and sustained glycemic control. It targets 7 out of 8 defects. Frequency of administration is reduced. Adherence is better, and overall cost is less. So this was the MESIDA trial, a combination of metformin, Sita, and DAPA. It was a phase 3 clinical study results. This was the permission obtained from the government. Study endpoints was to compare the changes from baseline hemoglobin A1C. Secondary outcomes were body weight, fasting, PP, and tolerability. The study design was 274 patients at 25 sites, 1:1 randomization, screening period for 4 weeks, treatment period is of 16 weeks, and once daily for 16 weeks. So this was the test product, that is your combination of the triple drug, and the reference product was the MSD's sitagliptin and metformin combination. So end of the study was at 16 weeks, and so 274 patients were randomized, and the reference, it was equal, both the equal number received the reference product as well as the test drug. So the key inclusion criteria is between 18 to 65 standard, already on metformin 2000 to 1500 milligram a day, and hemoglobin A1C value between 8 to 10. Exclusion criteria, I think all type 1 diabetes, hemoglobin, renal function, ALT, AST. So I think common pregnancy and all, they were all excluded. Results showed what? So the age of the patients was around 50 years. That's the usual age of diabetes in India. The usual, the weight of these individuals, yes, their BMI, if you say that, the BMI must be around 25. The duration of diabetes was around 7 years. And this was a change in a hemoglobin A1C. So you can appreciate the change in a hemoglobin A1C was something around from 8.8 to, in a test drug was from 7. So 1.45% there was a reduction in hemoglobin A1C. While in reference means the combination of Sita and metformin, then this was around 1%. So addition of an SGLT2 inhibitors contributed to further 0.5% reduction in hemoglobin A1C. So certainly with the fixed dose combination, the HbA1c is lower, is much lower than what you have had. Then the fasting glucose chain, you see that it has around 21 milligram per deciliter in that, while in the 2 drugs combination, it was around 8%, 8 milligram per deciliter. Then you see for the postprandial glucose chain, it was a much more with the combination of 3 drugs as opposed to the combination of 2 drugs. Then change in a body weight. You see that the change in the body weight was almost similar with the 2.9, means roughly 1 kg versus 0.8 kg with that. The safety review, the treatment emergent adverse events were almost comparable in both the arms. Gastritis, I think nothing specific. And GMI, I think they have talked about that. Hypoglycemia outcome between two arms was not available. So the test product, metformin 100 milligrams, sitagliptin 100 milligrams, and dapagliflozin 10 milligrams, superior to combination of metformin and sitagliptin. In terms of fasting, PP, and hemoglobin A1C. As far as safety was concerned, comparable, and both the products were safe and comparable. Thank you. Thank you for your patience here.
Yeah, thank you very much, Dr. Bansali. So let me invite our co-panelist, Dr. Bipin Sethi, to this audience. He doesn't need any introduction. Suffice to tell you that he is, the twine of diabetes and endocrinology from the southern part of our country. He's like elder brother to me, and he's always a mentor to me. And also we have got a co-panelist, Dr. Srirang Godbole from West, from Pune. Welcome, Dr. Sethi and Dr. Godbole. So let's continue with the two presentation, Professor Diffranjo's triumvirate to ominous Octet and the MESIDA trial results presented by Professor Bansali. So let me go first to the Professor Diffranjo. How do you look into this triple drug combination and the data which was presented just now, Dr. Diffranjo? What's your take on this triple drug of dapagliflozin, sitagliptin, and metformin?
Yeah, so I think that right from the beginning, we need to be going with multiple drugs. So I'm a big advocate of the triple therapy. I think you can see that it was quite effective in lowering the A1C. One can always argue as to which drug should be in the triple therapy. As I said, I believe that all the SGLT2 inhibitors are very similar. I believe that all the DPP4 inhibitors are very similar. So, and metformin, of course, is a very good drug. So you can combine these three in any way, shape, or form. Maybe in a later presentation, we'll talk about pioglitazone. Pioglitazone is the true insulin sensitizing drug. It's the only true insulin sensitizing drug. And particularly in the Indian population, there's a lot of insulin resistance. So I personally like pioglitazone. I use it as first-line therapy in all of my patients. So I would be very interested in seeing a combination pill that also has pioglitazone in it. But I think it's very clear from the data that were presented from the MESIDA trial that this triple therapy combination is very, very effective. And again, I think we need to go away from this stepwise approach of starting with one, adding another, and adding another. You can argue about which individual drug is more important. I would argue what's more important is you need to start on three right from the beginning.
Yeah, so let me invite Dr. Sethi for his comments on this triple drug combination and the data presented by Dr. Bansali. So how you do look into this triple drug combination? How do you think that these single pill would be helpful in our part of world? Dr. Sethi?
Well, as Bansali said, and everybody knows, the compliance and multi-drug therapy are major issues in all chronic diseases, including diabetes. We have accepted triple drug combinations in hypertension. There was some dissidence in accepting it for diabetes. And I think you would remember, and Dr. Diffranjo also would remember, that our country was the first one to introduce the combination of then glimepiride and metformin. So it improves the compliance. And the beautiful thing here is that these drugs are not going to innately produce hypoglycemia, which is a major deterrent to target achievement both for healthcare professionals and the patients. As long as the patient is free of hypoglycemia or free of the fear of hypoglycemia, there are two issues. The quality of life can be affected by occurrence of hypoglycemic episode or the mere fear of hypoglycemia. So when we have these drugs, which can get us to target without causing hypoglycemia. I guess that's something very, very important. And this is a trial. I think Dr. Ralph had asked in the beginning, are you doing trials before approval? Yes, we are doing. And this is the proof that this drug is effective and it is comparable to the data that has been produced earlier with the various other molecules. So this is going to be good. Initially, we are using these components separately. Now it's possible to have them in a single pill. One might give them in the very beginning if the person's HbA1c, let's say, is 8.5 or 9 to begin with, then I think it's a good combination, provided the person has got good renal function, because the dosage of sitagliptin is going to be modified if GFR is less than 50. Otherwise, I think it's a good combination for early onset disease, and the benefits of that were known to everybody, and they were greatly highlighted by Dr. Franzo about what is good metabolic memory and what is bad metabolic memory. So I think getting people to target with drugs that do not cause hypoglycemia is always welcome. Keeping them at that level for as long as possible is also welcome. And this drug combination is a good addition to that kind of treatment regimen.
Thank you. Thank you very much for your crisp comment. So let me shift my attention to Dr. Godbole. So Dr. Srirang, what's your first reaction to the MESIDA trial? You must have heard Dr. DiFranco's presentation and new data presented by Dr. Bansali, just now. I had the opportunity to present this MESIDA trial at this year ISICON. And I looked into this entire data in detail. I will come back to Dr. Bansali. I've got a few questions to him. But then before that, I would like to ask your comments on this particular trial data, Dr. Godbole.
So clearly, diabetes is a very complex disease with multiple pathophysiological defects, and we need drugs or combination of drugs which can address most, if not all, these pathophysiological defects. And if you have a combination which will address most of these defects without causing hypoglycemia, weight gain, and major risk of complications, and especially if it's in an FDC, thereby improving patient adherence, I think it's a welcome step. So I heartily welcome this combination. It's a very logical combination. It's a patient-friendly combination, and it also makes sense rationally, so to speak. So it certainly is a rational combination.
Great, thank you. Okay, so I will come back to Dr. Bansali and will ask him his view on certain results. So Dr. Bansali, you presented the MESIDA result, and I could see that there was significant reduction in HbA1c, despite a very modest reduction in fasting plasma glucose of 9 milligram and less than 20 milligram prandial blood glucose. But overall, HbA1c of 0.45, suggesting 0.5% HbA1c reduction was expected with a triple drug compared to the dual therapy with sitagliptin and metformin. But I was just, a little bit amazed that why there was no difference in body weight reduction with the triple drug therapy in this, MESIDA trial with this combination of triple drug, especially when you have got SGLT2 inhibitor compared to the dual drug. So what is your explanation? What could be the possible reason as to why you didn't find a significant reduction in body weight with the triple drug compared to the dual therapy? Dr. Bansali.
You need to unmute yourself, Bansali. Please unmute yourself. Yeah.
So yes, so your first comment was a reduction in hemoglobin A1c was 0.45%. I think we do expect like that, and even with the duration of diabetes around 7 years. Had it been a newly diagnosed type 2 diabetes, possibly would have been better. And even a baseline hemoglobin A1c would have been higher, it would have been better. But I think with this baseline hemoglobin A1c and the duration of diabetes, a reduction of 0.5% or 0.45% is reasonably okay. Your question about the weight, yes, certainly the weight loss was there, and there was no weight loss. There was hardly weight loss of 0.1.
0.90, yeah.
0.80. So the duration possibly it was only a 16-week study. So that may be the one explanation that they have this. And you see the mean BMI of these individuals it was something around 24, 25. So BMI was, even a baseline BMI was not higher. So that was another explanation for that, why we didn't see the weight loss around 2 to 3 kg or 2 to 4 kg, which we see usually after SGLT2 inhibitor therapy. So baseline weight, one, and secondly, duration of therapy, they were not so unfavorable in that way.
Yeah. The one data which is at the moment is not available with the MESIDA, and which I asked the Alkem to share with us, that what was the mean metformin dose in 2 arms? Because both, in the both arms, I suppose that metformin dose was kept constant, and it was somewhere between 1500 to 2000 milligram. But what was the mean metformin dose in 2 arms is not exactly known, and this could be one reason that maybe that in the sitagliptin arm, the mean metformin dose could be higher than the triple drug arm. I don't know exactly what could be the possible reason. So what is your take, Professor Diffronjo? Why we could not achieve a significant weight loss?
Yeah, so I think there's a pretty obvious reason that hasn't been brought up. So if you look at all of the SGLT2 studies, the mean weight loss is usually about 2 kilos at 6 months. And when you look at those studies, the mean drop in A1C is about 1%. Now, in this study, the mean weight loss is 0.9 kilos. That's about half of what you'd expect. On the other hand, the A1C drop was 0.45. That's half of what you would expect. And what that is telling you is that the amount of glucosuria was significantly different between the two studies. And so if you had measured the amount of glucosuria, I think that would have explained the reason why the weight loss wasn't as great. But a 0.5 drop in A1C and 0.9 kilos is exactly what you'd expect based on what's in the literature of a 1% drop in A1C and a 2 kilogram drop in body weight. So I don't find that to be so surprising, actually. In fact, I think it's consistent with what you would expect. And I think if you had measured urine glucose loss, you'd see the reason for that.
Yeah, so yeah, I agree with you. The question was to, in comparison to the test drug, because there was no significance. I could see the weight loss in the dual therapy of sitagliptin metformin arm was 0.8 kg, and it was 0.9 in the triple drug therapy. So the question was, in comparison to a DPP-4 and metformin, why addition of SGLT2 was not able to, further reduce the body weight? That was the question. So, yeah.
Well, your point about the metformin dose is also an unknown because in all of the big studies, the reason why metformin was initially thought to be an insulin sensitizing drug, if you go back to the early studies, metformin in the first 6 months usually causes a weight loss of about 2 kilos. And when you lose 2 kilos of body weight, that will cause you a little bit of improvement in insulin sensitivity. But if you don't lose weight, metformin is not an insulin sensitizing drug. So it may well be that there was a difference in the metformin dose between the two groups, and that's a partial explanation for the results.
Thank you so much. So let's take some questions from the audience. Someone asked, so I will project this question to Professor Diffronjo, although it's not related to the today's discussion, but someone asked, so where is the metformin at the moment during the first trimester of pregnancy? So are we absolutely comfortable using it during the first trimester of pregnancy, or you wouldn't?
Yeah, so this is a controversial topic and it still remains. So if you look at the OBGYN guidelines, they still recommend that primary therapy should be weight loss and, if necessary, insulin. However, I would say there's an abundance of data that says that metformin is safe. And so in the US, we do still use metformin, or many physicians still use metformin, although from the standpoint of the top recommendation, that still is diet plus insulin therapy if necessary.
Can I make a comment?
Yeah, please.
Yeah, so current guidelines for the use of metformin in pregnancy is that those women with the PCOS, once they conceive, they are allowed to continue for first trimester and then discontinue. I think the data which are available now, the children born with a metformin treated mother at the age of something around 8 to 9 years, they do have a features of metabolic syndrome. So that's why the reason for that, the metformin initially was like we had a MIG trial and a MIG tofu trial, which showed that the metformin is complementary to insulin therapy. And at least in half of the patients, the insulin can be avoided. But I think the fear now in the long run is developing a features of metabolic syndrome in these children who were born to mother who have been treated with metformin. So current recommendation even by the ADA-ASD when I reviewed yesterday. So that also mentioned that you can continue these at least women with the PCOS for the first trimester and then discontinue, and they favor the treatment with insulin rather than now adding metformin.
So the question comes: if someone has got a mild gestational diabetes and has planned to start with metformin rather than insulin, of course, the first trimester is gone because GDM is diagnosed in the second trimester. So you are recommending that one is absolutely fine to start with metformin when the GDM is diagnosed during second trimester onward?
Yes, now it is not a preferred drug. Yes, after the MIG trial and MIG tofu trial, the metformin was the drug which we also use in our clinical practice, and then added metformin if the targets were not achieved. But with the current guidelines, the metformin is not. I think the only drug which is left is insulin.
Yeah. Just to emphasize, first-line therapy is still diet and insulin.
Yeah.
You can use metformin, but metformin is not recommended above diet and insulin therapy.
Yeah, perfectly fine. So, Dr. Diframjo, I would come back to you and ask you a little different question, because you did the studies of SGLT2 and DPP4 and triple drug combination and compared head-on to either monotherapy with DPP4 or SGLT2. So IMPA alone, linagliptin alone. So what's your take on the genital tract infection of combination of SGLT2 and DPP4 versus SGLT2 alone? Would you really feel or believe that a combination of SGLT2 and DPP4, to start with, would able to have little less genital tract infection compared to starting with SGLT2 alone? Are you convinced of those data?
No, I think first of all, the incidence of, let's start with bacterial urinary tract infections and make it separate from genital mycotic infections, because there's a lot of confusion here. If you actually look at all of the big studies, in my opinion, there is no evidence that the SGLT2 inhibitors cause an increase in bacterial urinary tract infections. And you can go back and look at every big study that's cardiovascular renal, and you will not see an increased incidence, although there clearly is a warning in the package insert in the United States about an increase in bacterial infections. Now, in terms of genital mycotic infections, I don't believe that there's going to be any significant difference between mono versus combination therapy. And if you really emphasize cleanliness, which is the most important thing, that the incidence of genital mycotic infections will be reasonably low in the 1 to 2% range, as opposed in the 5 to 7% range, which is reported in all of the large studies, because I just simply think there was just not enough emphasis on cleanliness, both in guys and gals.
Yeah, but in your study, Dr. Diframjo, we can see that there was low frequency of genital tract infection in those who were on the combination therapy rather than the SGLT2 alone, although nobody looked into the statistical difference, but then the frequency wise, the GTI was quite frequent with the SGLT2 alone compared to the SGLT2 plus DPP4, and many such studies also actually propose similar kind of finding, and people actually enthusiastic people did a meta-analysis of all those genital tract infection with combination therapy and came to a conclusion that somehow there is a 50% lesser chance of having a genital tract infection if you start with a combination therapy of SGLT2 and DPP4 rather than a SGLT2 alone. So
the theoretical explanation behind this, I'm not convinced by this, is of course, if you start with combination therapy and you lower the plasma glucose concentration more than the monotherapy, the amount of glucosuria that's in the urine is going to be less. And the less glucose in the urine, because you have a lower filtered load of glucose, theoretically, there could be a decrease in the incidence of mycotic infections. But as I said, a rigorous trial looking at this really, in my opinion, has not been done. So in my hands, I don't see, first of all, I see a very, very low incidence of infection in my own patient population, probably in large part because I really heavily emphasize to the ladies that really after every time they void, they really need to clean themselves very carefully, and the same for the guys. And once you do that, then I think that the incidence of these mycotic infections drops to a very, very low level. And to me, that's more important than any potential difference between whether it's monotherapy or combination therapy.
Yeah.
Can I make a comment of this?
Yeah, please, sir.
Yeah.
Go ahead.
So I think your comment was based on that use of a linagliptin along with an SGLT2 inhibitors. There was a decrease in incidence of the genital mycotic infections.
Same with the DEPA and SEXA as well.
Yeah. But we didn't, I think, I've not published that data, but our observation with the vildagliptin and sitagliptin, along with the use of SGLT2 inhibitors, I think such protective or beneficial effect could not be seen. So maybe confined to Lina, that may be the one. But I think one thing I will tell you that because of frequent use of now SGLT2 inhibitors, almost 90% patients are getting SGLT2, we should be thankful to them. At least they have taught us to have a good genital hygiene, so which we hardly used to talk earlier. So that's a compliment to the SGLT2 inhibitors. And one more experience, our many patients in fact got a circumcision done by the urologist once they had a melanopostitis. But after the circumcision, they didn't have a GMI.
Perfect. So I will shift now again back to the triple drug, and I have now a question and comments from Dr. Godbole now. So when you're looking back into this MESIDA trial and triple drug therapy, now we are bombarded with triple drug therapy in India, and several pharma company has got different combinations. Someone has got vildagliptin, dapagliflozin, metformin. Someone has got sitagliptin, as you saw, sitagliptin, dapagliflozin. And in future, you will find all those empagliflozin. At the moment, because Impas patent is there, so we don't have any Impas dual triple drug therapy. I mean, I'm talking about generic. So how do you look into this data of sita dapagliflozin versus vildagliptin dapagliflozin along with metformin? Do you have any special comment to make here?
As far as I know, vildagliptin as a 100 milligrams single dose is available only in India. I don't think outside India, vildagliptin 100 is available. So there is limited study on vildagliptin 100, but frankly speaking, I don't think gliptins differ much from each other in terms of efficacy or for that matter, safety, except, something like hepatic impairment where vildagliptin is supposed to be avoided. But otherwise, in terms of efficacy, generally speaking, I don't think gliptins differ much from each other. So I think the choice of gliptin is secondary, unless, of course, you're dealing with a case of renal impairment, where for some gliptins you need to reduce the dose. But otherwise, in someone with normal renal function, normal hepatic function, which most of our patients would be having, I don't think it makes much of a difference which gliptin you're using, frankly.
My question, Dr. Godbole, was would you find sitagliptin, dapagliflozin, metformin combination to have a similar kind of outcome as compared to vildagliptin, dapagliflozin, and metformin? I'm talking about triple drug therapy, not between two DPP4 inhibitor, but rather choosing between a triple drug combination where you have got a sita, dapa, metformin and you have got a Vilda-DAPA metformin. Would you like to choose between these two for some reason or otherwise?
So the only difference between the two triple drug combinations you're mentioning is the choice of the gliptin. Otherwise, I believe what you're saying is the DAPA and the metformin is just the same.
Right.
The only difference is between the gliptins, and that's what I'm saying. The gliptins, I do not believe, differ from each other in terms of efficacy. So I don't think efficacy-wise, one triple drug combination scores over the other.
Okay, so
let me just comment on that. And I would agree completely. And remember, in my presentation, just to make that point, I also showed you data on dapagliflozin, and I showed you data on empagliflozin, and I showed you data on sitagliptin, and I showed you data on linagliptin. And the results are virtually the same. So I think whether you're talking about an SGLT2 inhibitor, I think they're all the same. If you're talking about DPP4 inhibitor, I think they're all the same. The only big difference in the triple combination therapy would be if you put pioglitazone. And there, I think you get a very, very different effect using pioglitazone.
Yeah. So, but then, Dr. DiFranco,
I think of this, then it will not be a triple, it will be people will make a 4-drug combination, including pioglitazone.
My question, I'm sorry, Dr. DiFranco, I would beg to differ from you here and with Dr. Godbole as well. My question was not only intention to choosing between two DPP4 on HbA1c background. Let's not forget that SGLT2 has come to the top because of the cardiorenal advantage. Now, I would be circumspect to use a combination of sexagliptin with a SGLT2 inhibitor, given the data which we learned through the Saber-TIMI trial, that the entire intention of using a SGLT2 inhibitor is to prevent or to treat heart failure. Where is the data of vildagliptin cardiovascular safety? Is there proof that vildagliptin do not increases heart failure like sexagliptin? For sitagliptin and linagliptin, we do know that these are neutral when it comes to heart failure. But no, so that was my intention of asking this question.
I think that I will just add it here. We have got a much more robust data for sitagliptin regarding cardiac neutrality. We don't have such robust data for a vildagliptin, and yes, we know about the saxagliptin and heart failure. So that's the one point, is that the cardiac neutrality or a cardiovascular outcome, at least no harmful detrimental effects by sita, but we don't have a data for a vilda. And second point, which Dr. Godbole also made it, there's no difference in efficacy, but the DPP4 inhibiting capacity of the sita versus vilda. Sita is more as opposed to vilda. And even some studies show that reduction in hemoglobin A1c is 0.1 to 0.2% more with sita than with vilda. So I think there's a leanness of the physicians towards choosing the combination of sita, DAPA plus metformin instead of vilda, DAPA and metformin.
And third point I would add here, and I would like to listen from Dr. Sethi also. So although we have got sitagliptin 100 vildagliptin 100 milligram, given not by DCGI and people are using it, but then do you know the safety of vildagliptin 100 milligram? Why it is not there? It wasn't there in the United States. The vildagliptin, Novartis went to the US FDA with 100 vildagliptin to start with, but they were returned by the FDA to cut it into 2 to 50 milligram twice daily because of increase in liver enzymes and the skin reaction. Now, what led Indian regulator or the boss sitting there to approve vildagliptin 100 milligram? Where is the evidence of safety? Dr. Sethi, your comment.
Well, I am not the approver, so I cannot answer that question. However,
your comment,
I think the closer look at the data which was submitted to the regulatory authorities with 100 milligram did show a slight increase in the liver enzymes. And that was the question that we had asked those people also, but the findings were not really very significant, so they brushed it aside. But a slight increase in the liver enzymes was seen even in the data that was submitted for approval for the vildagliptin. So you are right that the same very reason which did not lead to its approval for a single dosing, apart from its pharmacokinetics and pharmacodynamics, was that the liver issue was there with the 100 milligram dose. And because it was going off patent, because it was facing competition from Sita and generic gliptin out of here, they tried to introduce a single daily formulation. Since I said I'm not the regulator, maybe the difference was not considered significant by the regulator, and they approved the 100 milligrams.
Yeah, and the fourth issue with vildagliptin once daily, barring increase in liver enzyme, that there was an increase in QT interval prolongation
As well.
100 milligrams. So that was another issue, to which the US FDA returned Novartis to bring back with the 50 milligram twice daily. So that was my question, and that was the entire intention of asking this question to you, Dr. Godbole, that we don't have CV safety of vildagliptin, we don't have in general safety of vildagliptin 100 milligram once daily. So how can one would be keen to use a triple drug combination having a it was not a matter of efficacy. We are talking about the safety. We are talking about the cardiovascular outcomes. So we are preferring the triple drug with SGLT2 with the intention that we are going to protect heart and kidney in the future, and yet not knowing whether the other component in this triple drug, like vildagliptin, is really cardiovascular friendly or not. Any comments?
Yeah, in that triple combination, I must also point out we do not know the CV benefits or safety of metformin as well, because that came before the US FDA mandate.
No, but then we know that, if once you have got if you look at the whole cardiovascular outcome trial, more than 75% patients were receiving background metformin therapy. So there is no fact denying that the SGLT2 inhibited cardiovascular, benefit is independent of the background metformin use. So this will not interfere in the cardiovascular outcome. But the point is whether the CV outcomes of SGLT2 would somewhere compromise because of the DPP4 component in that triple drug. That is the question we are raising here.
Yeah. I think there's one more comment regarding metformin. Yes, we don't have a RCTs for a metformin as far as CVOT is concerned. But I think UKPDS shows a very clear vision, because the metformin was the drug which was primarily used in that trial and showed that in the long run, the cardiovascular outcome was better. So I think we have data from UKPDS which shows that, of course, it is not an RCT.
So, Dr. Diffronja, I will come back to you and we'll ask your preference. If you would have been a CEO of a Indian pharma giant, full oral drug you would like to have from
he will like to have more 5 liters.
No, I know. So triple drug. So what 3 drug? So tell me the name of the 3, drug which you would like to, put into a triple drug FDC.
Yeah. So you're going to have to put metformin in because it's used everywhere in the world as first-line therapy. Okay, so I would put metformin in. Now, we're talking about a pill. Second drug, quite frankly, for me, would be pioglitazone. And that's the power horse for all of the drugs. And the third would be an SGLT2 inhibitor drug. And if I were going to substitute out one, I would substitute out the metformin and put in a DPP4 inhibitor. But for sure, pioglitazone would be there. The SGLT2 inhibitor would be there. And what would be the third drug would, you could choose either of, kind of your own preference. Now, the way we did the triple therapy, of course, was using a GLP-1 receptor agonist, but that's not in a pill. That's an injection. That's a whole different story. And the 6-year data, I think, are pretty clear. If you use a GLP-1 receptor agonist with pioglitazone and metformin, you have incredible efficacy in cardiovascular protection for upwards of 6 years. But from the practical standpoint, people are not going to take an injection for 3 years or 6 years. And these newer drugs in the United States, the GLP-1 receptor agonists, are like $1,000 a month. So cost is prohibitive. And having a DPP4 inhibitor in a pill, I think from the cost standpoint, is a major advantage.
Thank you. So in the last 5 minutes, I would like to take few questions which have been sent to me by the organizers. I could see a few questions. So anyone can comment as per your wish. Someone asked me whether genital infection can be controlled by using any particular drug with a SGLT2 therapy to, as a prevention aspect. I'm sure he must be asking in the way that would you like to give any prophylactic drug to prevent genital tract infection along with SGLT2? So Professor DiFranco is nodding no, absolutely.
No.
Don't have any
Clean-
evidence to
Cleanliness,
Cleanliness.
most important.
Yeah. Okay. So someone is asking the triple drug of SU-met-pio versus depa-ceta-met. How do you look into this triple drug of sulfonylurea, pioglitazone, and metformin, which we have in India, at least 1,000 brands here, and now we have got at least 100 brands with triple drug of depa-ceta-met. So how do you look into this triple drug of SU-met-pio versus depa-ceta and metformin?
I would stay away from the sulfonylurea because one of the benefits of the triple combinations we've been talking about is lack of hypoglycemia. The only thing this SU could do is reintroduce the issue of hypoglycemia. And the other combinations that we've been talking about really are quite safe, and you don't have to worry about hypoglycemia.
Absolutely. So before we wrap up, let me have a 10-second comment on triple drug from our 3 Indian panelists here and their Ceta and metformin. I will start from Dr. Godbole. So how do you look into this triple drug launched by Alkem with the evidence of a double-blind randomized active comparator trial? How would you like to see this drug for the future?
So with the background of a comparator trial, I believe it gives more confidence in the use of this triple drug combination, which is intuitively rational, addresses many, if not most, of the pathophysiological defects without causing any significant adverse events, save for genital mycotic infections, which I believe can be largely avoided by emphasis on cleanliness. So it's a very good combination. I believe it's increasingly becoming the combination of choice in most of our Indian diabetic patients, especially those with an HbA1c of say above 8 or those with multiple comorbidities. I think this would be the combination of choice. Thank
you. Dr. Bipin Sethi, your comments, please.
Well, whether you add these drugs separately or give them as a pill, I think it's good to address multiple mechanisms, and compliance issue is settled with this. And as everybody has highlighted, this is an era of SGLT inhibitors. In the past, we were talking about let's have a patient who does not require statin, and we've cleared that. Now, I guess the issue is all patients should receive SGLT inhibitors.
Yeah.
And this is a welcome change, whether you want to give it 3 separate drugs or one drug is your individual thing. But earlier on in the disease, which you're talking about, to erase the bad metabolic memory with good renal function, which most of these people will have, I think this combination is a good combination. I again reiterate that the GFR should be calculated so that we don't end up giving a higher dose of Ceta, though the harm with that is not clearly proven, but there's no good in administering a drug which should not be given in the dosage that the renal impairment mandates.
Fair enough. Thank you so much. Dr. Bansali, your take.
Yes. So all patients with type 2 diabetes should have an SGLT2 inhibitors and metformin. Yes, unless not tolerated, then there are different issues. But I think all should get a cardiovascular benefit as well as the renal benefit of this class of drug. And this combination will definitely increase the adherence, compliance, cost will also be lesser, and side effects will also be minimized. So I hope this combination will be useful. And anyone who is having a hemoglobin A1c between 7 to 8%, the triple drug combination to begin with can be a good choice. And again, I will tell you that the verified trials, they used even Vilda and metformin even at a hemoglobin A1c of 6.9%. So because these drugs are either glucose dependent or glucose independent, and particularly reducing the beta cell glucotoxicity instantly, particularly these SGLT2 inhibitors. That's the beauty of this class of drug. That's why the efficacy even of the DPP4 inhibitors is also enhanced with a combination of use of SGLT2 inhibitors. So this is a welcome change, and every Indian patient or every of our own people should get a benefit of this class of drug. I think the cost will also be very, very affordable. So this triple combination will definitely make a change. And I think we'll try to attain the target hemoglobin A1c in majority of our patients.
Thank you. So finally, I would come back to Professor DiFranco. And before I ask you to put your comment, let me tell you in India, we have got 1 tablets of dapagliflozin. Even if you look at the Forxiga, the innovator dapagliflozin in India, as a cost 10 cents compared to $18 in United States per tablet. So here, the tablet of dapagliflozin in India is less than 10 cents. Just imagine the number of generic dapagliflozin which we have in India. And if you look at this triple drug of dapagliflozin, sitagliptin, and metformin, this is also hardly 15 cents from the from the US perspective. So this is the cost of a triple drug in India. Now, if I have have got the opportunity to take a US FDA approval, and tomorrow you get this product in United States, how do you look into this triple drug combination, Professor Diffranzo?
Well, I like the triple drug combination. I pretty much agree with what everybody else said. The 2 comments that came up earlier, I just reiterate, I wouldn't ever add a sulfonylurea because I think that you have to now introduce this issue of hypoglycemia. And I personally would add pioglitazone as one of the drugs. I like the triple combination. I think actually companies should try to get these drugs approved in the United States. I think it's a big benefit for patients to have 3 drugs in 1 tablet. If you have educated patients who can afford it, of course, I would use always a GLP-1 receptor agonist, and particularly one of the new ones. That is oftentimes not practical. We know that the non-compliance is about 50% at 6 months, and not too many people can pay $1,000 a month unless you have insurance for these drugs. So I think there's a big need for something that's simple, that patients can take, and has no side effects or minimal side effects, and gives you cardiovascular protection. So I would always have the SGLT2 inhibitor in there. I like the pioglitazone because it's the only true insulin sensitizer, gives you cardiovascular protection. And then I think you can pick between the metformin and the DPP-4 inhibitor. But I am definitely in favor of the triple combination.
Thank you so much, Professor Diffranzo. So on behalf of all the faculty house here and my co-panelists, I would like to thank the ALKEM for giving us the opportunity, and in particular to me, to moderate this session with all big shots here. I'm, a great learner from all of them. So back to organizers for the final comment to wrap up this session. Thank you, everyone.
Thank you.
Thank you so much, sir, for excellent feast for knowledge, both from theoretic perspective and from clinical practical perspective. So on behalf of ALKEM Metabolics team, I would like to thank Professor Diffranzo for excellent deliberation, lot of practical and points, and lot to learn from you, sir. Thank you so much. Dr. Singh, sir, great moderation and giving us clinical perspective, real world perspective, so that everybody can learn from each other. Thanks to Dr. Bansali, Dr. Sethi, Dr. Godbole, sir, for their deliberation and time and opinions on management of diabetes in India. So with this, I would like to kind of once again thank each one of you for your precious time, valuable opinions, and great learnings for taking the move towards diabetes controlled India. Thank you so much. I would like to just invite our sales person, Mr. Raghavendra or Mr. Sashi, just to share vote of thanks from on behalf of ALKEM Metabolics team.
Thank you very much, Dr. Mayur. First of all, I would like to thank you, Professor Ralph Diffranzo, sir, for honoring the session, for gracing the occasion with all the eminent doctors. I would like to call this summit not as a smart summit, but a powerhouse summit, a legend summit, a titan summit, titans of diabetes therapy in India, and titan of global, the originator of Ominos Octet, the right approach to manage type 2 diabetic patients, not only in India, but across the globe. Thank you, AK Singh, sir, for giving us powerful take-home messages, sir, for all across India, how we should approach type 2 DM patients. Thank you, Bipin Sethi, sir, for saying smart session memory. You said metabolic memory, it should be smart session memory for Dapanam trio, sir. Thank you very much, Anil Bansali, sir. You said Dapanam trio or triple combination should be for our own people, not only in India, but across the globe, should be treated with triple smart combination. Thank you, Sri Godbole, sir, for your insights and take-home messages, sir. It will be very helpful for all the delegates across the country. I would like to say once again, sir, thank you to all esteemed doctors who have attended this session. On behalf of the original research product of Alkem, Dapanam Trio, the Smart Pill, would like to thank again all the esteemed speakers, moderators, sir, all the esteemed faculties, esteemed doctors who have attended, Dr. Mayur on behalf of our entire team, Ganesh, my colleague Ganesh, who has coordinated with all international faculty as well as our powerhouse of India, all the doctors, and all our entire field force colleagues who have organized, registered our doctors, invited them to attend the session. This session will really go a long way in history. It will be memorable for long time to come, sir. Thank you very much once again, sir. Thank you very much, sir.
Thank you,
sir.
everyone.
Thank you very much,
Good night.
sir. Thank
Bye
you.
bye.
Good night, sir.
Good
Thank you,
night.
sir.
Bye bye.
Thank you, sir. Bye.
Bye.
Sir. Bye, sir.
Thank you, everyone.